Okay, we're live.
Hi, good evening, everybody. This is Dr. Tiwari from Midwest Breast and Aesthetic Surgery, and we are very honored today to have the opportunity to speak about a very important topic to our patients, and that's the importance of a flat closure. And in our discussion today, we'll really define what that means. It's my pleasure to present the Flat Closure Now board, and we've got Cassandra, Katie, Kim, and Melissa, and we've prepared a lot of questions. We want to make this real conversation, and I really think that this is probably the first time something like this is put together, which is really a deep dive into what it takes to achieve flat closure after a mastectomy. And I think part of the reason that we're here is that there are a lot of issues for patients and for physicians to create alignment in expectation. And this, I think, is an important first step to be able to do that.
Mm-hmm.
All right, so we may just jump right into it, and some of the ladies will ask me some questions, and we'll just have a conversation.
So it seems that going flat after explant usually involves two things: removal of the implants and the capsule, and then contouring to get a flat result. What is the standard of care here?
A really good question. So I think we should always define just a few terms. So what is an explant? I think the better term for an explant is really a total capsulectomy and implant removal. And so what does that mean in my practice? My practice, talking about the mastectomy patient here, making an incision again through that prior mastectomy incision, identifying the pectoralis major muscle, because oftentimes the implants are placed below the muscle, removing the capsule, which is kind of like the rind of an orange. It's the orange, not the rind. It's removing the muscle, which in this example is the rind, off of the orange, removing that capsule and implant off of the chest wall. I think from a functional standpoint, removing that encapsulated scar is very important, because a lot of patients have had a mastectomy with submuscular implants, particularly the radiated patient. They have a lot of discomfort because of their submuscular implant placement. But the more challenging part, in my opinion, is recreating a flat contour. And that really depends on the patient's pectoralis muscle anatomy. I think the standard of care is re-siting and resuturing the pectoralis major muscle, which is the big muscle on your chest. That's how we swing a tennis racket. Repositioning that to its normal anatomic condition. And then I do a lot of what's called auto-augmentation, where I'll take the margins of the skin and almost try to use them to augment the area of the indented scar, and at the same time use that skin and not leave it redundant at the chest wall in order to try to get as even a closure as possible. Now, I'm sure we'll talk about fat grafting and some other techniques. But for me, at that very first operation, a flat closure at the time of explant means total capsulectomy, restoring the pec muscle to its normal anatomic position, and then addressing the excess soft tissue, oftentimes in the form of an auto-augmentation.
And are there cases where the skin doesn't need to be trimmed after explant to get a flat result?
I think it's a really good question, because it really depends on whether they've had radiation treatment. In general, someone who's been radiated, if anything, you have a paucity of soft tissue. You have a lack of soft tissue. And I take the example of a patient, let's say, who is 5'5", 105 pounds versus 5'5", 195 pounds. And those two people are going to have very different soft tissue dynamics. It also depends on whether the patient had a lymph node dissection. Because oftentimes when a lymph node dissection is done, some of the soft tissue attachments at the lateral part of the chest are released. And that's how you get that very kind of irritating, uncomfortable area at the side of the chest. I see that less in my sentinel node patients than my actual lymph node dissection patients. But in general, how much of the soft tissue you have to contour is a combination of those variables. Was the patient radiated? Did they have a lymph node dissection? What type of lymph node dissection? And what are their body mass index characteristics?
Is there any type of repair that has to be done to the pectoral muscle during the explant surgery?
Yeah, I think it's a bit of a controversial issue, in my opinion. I think certainly on the cosmetic side, there are certain people who do not repair the pec muscle. My general philosophy as a plastic surgeon is to replace like with like. And if something was in a certain normal anatomic position at one time, it only makes sense to me that we should put it back to its same normal anatomic position, which is flat against the chest wall. Now, for a lot of reasons we can talk about, some of the historical implants have been put below the muscle for a very long time. But I think the functional problem there is very, very clear to patients. So from a functional standpoint, I also think it's important to put the muscle back to its normal position. And then finally, from an aesthetic standpoint, if you don't replace the muscle, what happens with the pec muscle is it window shapes. Like putting a window shade down and it snaps back up. It's very similar with a pec muscle. Once you've released the capsule, if you've released any cellular matrix that was used at the time of the mastectomy reconstruction, all that causes the pec to window shade up. It's an unsightly line higher up on the chest. So to deal with that unsightly line, you have to re-advance the muscle back to its normal anatomic position. And then you have a transition between the muscle ends and the chest wall begins. And sometimes that's where things like backdashing come in.
Wow.
Does that make sense? I'm trying to.
Yeah.
Okay.
While we're on this topic, it might make sense to skip forward to a couple of things that I was going to ask about anatomic landmarks. Now that we're talking about the contour, so what you're talking about, pectoral retraction, and that causes like a bump or like a discontinuity in the contour there. I guess a lot of what we see, a lot of the patients that I've spoken to show me pictures. They're dissatisfied with their contour after explant. They have concavity that's made more pronounced by like a large, armpit fat area. Is pectoral retraction part of that? Is that making that worse?
I don't think that the large armpit area is due to the pec retraction. I think that is due more to when a mastectomy is done. What is a mastectomy? Mastectomy is removing the breast tissue. But where are you removing it from? Well, the breast lives between the pec muscle and the overlying skin. So to remove the breast, you necessarily have to remove those attachments from the skin to the breast. And now what was, in essence, a continuous anatomic structure has now been disrupted. You can imagine that skin at the side of the chest, also the skin at the central part of the chest, but more noticeably the tissue at the lateral part of the chest sort of falls away. And one thing that we oftentimes do, and again, this is at the time of a breast reconstruction, but it certainly can be done at the time of a mastectomy, is to restore that kind of lateral contour, that lateral mammary fold. Now, if a plastic surgeon is not involved at the time of the mastectomy, most breast surgeons are not thinking about doing that. They're not thinking about putting in absorbable sutures to restore the, what's called the fascial continuity between the lateral chest and the pec muscle. And in fact, even at the time of reconstruction, if you don't restore that normal continuity out laterally, it's very hard to fix after the fact. In fact, I think it's impossible to fix after the fact. And it's really a point of education that's worth some discussion among the breast cancer surgery community. I'm talking for the oncology community, how we can restore some of that lateral continuity, which is a big problem for patients.
That's interesting. Thank you.
Wow.
Yeah, but so many of these questions are the anatomy, like you pointed out. What are the key landmarks? The breast goes from the inframammary fold area, actually below the pec muscle, just below the pec muscle. It goes out laterally to what's called the anterior axillary line. You can imagine dropping a line from your armpit down. It goes almost up to the clavicle, the tail of the breast, and then it goes to what's called the parasternal border. And so all those anatomic landmarks have to be respected. And if they're not addressed sometimes at the time of the mastectomy, then it becomes hard to fix them later on with some of the techniques that we'll talk about, although I think the techniques can improve this.
Well, while we're on sort of going in that direction,
I'm losing you.
A little bit about fat grafting.
Yeah.
And why don't we talk about how do you address that with your patients, whether somebody needs fat grafting or not?
I think of fat grafting as a filler, not necessarily as a mechanism to create a breast mound. Now, there's one big caveat to that, and we'll talk about that in a moment, but I think fat in general is good for addressing concavities, deformities, indentations, and being used as a filler. So, what are we doing with fat grafting? Well, we're liposuctioning perhaps the thighs, perhaps the flanks, perhaps the abdomen, preparing that fat for sterile reinjection. And the fat is like sowing seeds in your garden. You can only sow a certain number of seeds into the garden. If you don't put enough seeds, well, you don't get enough of a yield. If you put too many seeds, it's not going to improve your yield. So the fat has to be placed in a hospitable environment, which means not necessarily radiated. A radiation environment is not a hospitable environment. It needs to be placed to the right quantity, into a certain surface area. And again, it's useful for filling defects, indentations. So oftentimes I'll use it in the upper chest area where someone wears something lower cut. You don't want to see the indentation of a prior mastectomy. It's very useful in people that are quite thin, and you can see their kind of bony rib cage. So I think that the fat grafting works best in those settings. There are some considerations with fat grafting, which I think are very worth talking about. But I did mention when fat can be used as a breast mound, and many people I'm sure have heard of Roger Curry and the Brava device. The Brava device is a useful device. We have one in our practice. It's essentially a big suction cup. If you remember Madonna in the 1980s for her, I can't remember what the tour was called, but her.
That's all.
I know. So in Madonna's tour, she had those big cone-like, and the Brava is very similar, and it essentially is like a large suction cup, which draws growth factors, vascularity, blood supply to the chest wall to make the environment more hospitable, to increase your fat placement and increase your yield. And we've done Brava. I've seen some great results with Brava. The problem with Brava is a compliance issue. It takes anywhere from 6 to 8 hours per day for anywhere from 2 to 3 weeks prior to the operation. And Brava takes more than one round. It can take as many as 3 to 4 operative rounds to develop a breast mound. That's, a fair amount of surgery. I think the two considerations with fat grafting, number one, it goes back to this issue of the hospitability of the environment. About half of fat absorbs away. And that's true in every single large study. So if I place 200 cc's of fat, 30 cc's is an ounce, so about 6 to 7 ounces of fat to somebody, about half of that will go away. And that's where these reoperative surgeries sometimes come up. The other problem with fat is although some of it goes away, just absorbs away, some of it can get hard. And that's really not good in somebody who's had a mastectomy. And now we have a hard area, and that's very anxiety provoking. It leads to additional imaging, and it leads to the potential for additional biopsies, all of which are very unfavorable. So I think fat grafting has its usages. I think it's really important to understand that there are limitations to it. And you can only get so much out of fat before you're over sewing that garden.
So it's not a guarantee for somebody going flat to be able to have fat. I mean, there's no guarantee that fat grafting will ensure that you don't have concavity after explant. Is that correct?
Correct. I think that it will help. I think fat grafting is almost always helpful. But I think you've got to respect the limitations of the technique. And I think it has, real limitations. And I think that you've got to be careful kind of over promising and under delivering what this technique can do. So I'm very sort of cognizant of talking to patients about the goal with fat grafting is to address areas of concavity, deformity, indentations, not to create a breast mound. I think the final issue with fat grafting is, and now we're really kind of getting the weeds, which is good. That's what this conversation is for. It's hard to fat graft at the time of an explantation. Well, why is that? Well, to fat graft, you need a potential space, not a real space, a potential space, because you need to be able to fill something up. If you have a big space and you just squirt fat into there, how is that fat going to live? What's it going to live off of? What's it next to? It's next to other fat that also doesn't have a blood supply. So fat grafting is really best done at a secondary operation, particularly for the mastectomy explant patient. Fat grafting at the time of explantation, you're essentially placing fat into a real space, not a potential space. And there you run the risk of an infection because fat has no intrinsic blood supply. Unlike a deep flap, for example, it has no intrinsic blood supply. So if it doesn't have a blood supply, most of it will just absorb away. Some of it will get hard. And then we're back to that same concern of additional imaging and a biopsy. But the point there is, if we're fat grafting, I'm typically doing it at a secondary stage once the patient is healed and that real space is healed and we're developing potential.
Can I ask along these lines? Most patients going flat after explant, the reason they would ask about fat grafting is because they're concerned about concavity. Yeah. And what we've seen is that concavity can be really pronounced after explant compared to women that go flat at the initial mastectomy. I guess the question on a lot of our minds is why? Number one, why is that? Why are women after explant so concave so often? And the second part of it is there anything other than fat grafting that can be done about that? Will it improve over time? Like what can a woman who's explanted and now faces very pronounced concavity, what are her options?
So if this is an excellent question, I'm going to ask you folks a question. So when you hear this among patients, where is the area of concavity? Is it centrally? Is it down below? Is it up above? Is it at the side?
It's in the cavity where the breast glandular tissue was removed, in the center.
So I think the first point that you made, why is the concavity worse after explant than after a flat closure at the time of mastectomy? It has a lot to do with the amount of scar, the capsule that develops around the tissue expander, around the implant. I mean, think about it. What is a tissue expander? A tissue expander is there to create an anatomic space that does not exist. It's why they're so uncomfortable, because they're creating a real space in the area of the potential space that was beneath the muscle. Now, as we're doing some more pre-pectoral reconstruction above the muscle, we're seeing less of this, but still the majority of reconstruction is done below the muscle. And so you're creating a space there, which means there's a lot of scar. And there has to be that capsule because the implant doesn't do anything. It just sits there in the real space that the tissue expander has created. In going through that process, not only have you developed a lot of scar, which leads to indentation deformity at the time of capsulectomy and explant, but you're also really thinning out the overlying tissue. Well, you're expanding it out. So you're losing some of the subcutaneous fat component as opposed to somebody who just has a flat closure. Because then you're not going through the expansion phase. We're not talking about direct implant reconstruction here, which is still the minority of what's done. We're talking about the traditional approach, which is a submuscular tissue expander placement. You're literally compressing that overlying subcutaneous tissue. So whatever sub-Q fat you have there, which is essentially a camouflage, is then compressed, leading to more of these problems that we're talking about. So that's kind of my thought, why we do see this more in people who had an explant versus a flat closure without any tissue expander reconstruction.
Is there any effect or deformation of the rib cage at all, or the chest wall in any way when a woman has had expanders or implants? Is that part of it?
There really can be, particularly in thinner women. I mean, I had a patient, this was many years ago, and she was an older lady, had some, bony osteoporosis. She actually had a rib fracture from a tissue expander. So again, the tissue expander is creating the space and it's pushing out, but for every action, there's an equal and opposite reaction. So there's also some pushing back at the chest wall.
I'm flabbergasted because I'm that woman. I explanted 3 months after implant. I scar horribly. If I don't know, that's an old scar. I get very raised scars. I have a lot of keloidal scars. My C-section scars were horrific each time. They had to cut them out, and they were so big. And I just hearing this I'm so glad I explanted, because I already felt like I was having issues with it under the chest muscle. My scars now are very raised, very pronounced, and I can't even begin to fathom, and I'm a very, very tiny person. It's hard for me to fathom how I would have looked after several years of having implants. And I am so grateful and thankful that you are explaining to me how my body would have reacted, or talked to me about some of the things I was experiencing.
Yeah, I think that, it's important to understand, we all do scar differently. And what makes, I think, the topic of flat closure really a very difficult topic is there's so much variability, not only among people's cancer treatments, that's a whole set of variables. Not only with regard to their body mass index, that's a whole set of variables. Not only in regard to their breast size, which is independent of body mass index sometimes, that's a whole set of variables. And the final set of variables is your genetics when it comes to scar healing. Asian people, African American people tend to have more hypertrophic, more keloid scars. Western Europeans tend to have more light scars, and there's a whole spectrum of the thickness of scars. It has a lot to do with the thickness of your dermis. And so those are all issues that impact the ultimate outcome. I think they impact not only your external scars that you can see for the mastectomy, but also, the degree of capsule that you have. I think another big area here, something that we're seeing a lot in the breast implant illness community, is in our data, we have found a reasonably high number of patients with a bacterial contamination or fungal contamination of their capsule. I don't know the importance of that yet, but my suspicion is that part of what's going on for patients that have what we now call breast implant illness, but back in the 90s, when implants were first pulled off the market, was known as ASIA, autoimmune inflammatory syndrome induced by adjuvants. And so the point there is, if the underlying mechanism is inflammatory, it can be inflammatory to a antigen, a pathogen like bacteria or fungus, like we're seeing in some of our capsulectomy specimens, or it can be an inflammatory response to something like a silicone foreign body. So I think that those are both components of what we see in the breast implant illness patients.
That kind of leads to some questions I had too. Like, do you consider the explant in the case of patients presenting with breast implant illness? Do you think their symptoms to be therapeutic? I mean, do you consider explant in these cases for them to be therapeutic, or is there an actual reason that they need to be explanted?
So it's a really good question. I think that there are a lot of reasons why patients explant. I think at probably the most common thing that I hear about and I see among my patients is discomfort. And that discomfort typically is range of motion at the shoulder girdle with reaching and stretching. A lot of folks have pain in the scapular tip because the pec muscle reaches around to the serratus muscle and inserts into your scapular tip. So I would say the first thing that brings patients to explantation after mastectomy is discomfort. I can't do the same exercises. I can't pick up my toddler. I can't do my normal activity in my occupation. I think those sets of problems is probably the thing that takes patients to explantation more than anything else. Now, I think that with the FDA hearings and the concern for ALCL lymphoma, which has been associated with certain types of textured implants, I think that patients have concern, particularly if they have a textured implant. Now, there's no FDA or American Society of Plastic Surgery recommendation as to what to do in terms of removal for these textured implants, but I think it is a cause for concern, understandably, among patients who have those implants. I think the final issue is the issue of breast implant illness, which I think in some ways is related to the discomfort piece that we touched on, and in other ways has a whole other set of problems, anywhere from cognitive dysfunction, brain fog, hair loss, joint swelling, rashes. It's hard for me to explain how all these things are related. If you look at the MD Anderson study from late 2018, what they found was an increased incidence of autoimmune issues in patients who had undergone implantation. And these were issues like Sjogren's syndrome and lupus. And that study can be criticized and has been criticized, but it also reflects a very large number of patients, almost 100,000 patients. So for the more systemic issues, I tell patients, I don't have a good predictive sense of how you're going to recover. And there's a lot of variables. There's above the muscle, below the muscle, smooth versus saline, ruptured versus not ruptured, textured versus smooth, greater than 10 years versus less than 10 years, for example. I think all these variables have to be evaluated in order to get a sense of who is recovering and when they recover. Do things like the MTHFR gene mutation play a role here? I don't know. This is the type of data that needs to be investigated back in the 90s when implants were first pulled off the market for cosmetic purposes, silicone implants. But I think there's an opportunity to look at this from a more scientific standpoint now, so that we can answer some of these questions. But those are the variables that have to be figured out. But again, to answer your question, I don't know if the systemic issues are going to get better. I can say that I have many patients. The improvements have been dramatic. So, but I have patients who have not improved. Again, it's hard for me to have a predictive algorithm.
In those cases, when you evaluate that, is that when you get inside, like we hear the term in block versus total capsulectomy, what is the importance in those cases when patients are having the symptoms to remove the entire capsule?
Yeah, it's a really good question. I think that a en bloc, the term en bloc really refers to an en bloc resection of a cancer. So when you do an en bloc resection of a cancer, you have a complete removal of the cancer. That term has been adapted to en bloc capsulectomy, which suggests that you're removing the entire capsule from underneath the muscle, from off of the posterior chest wall. A total capsulectomy is removal of all of the capsular tissue, but perhaps not in one single en bloc specimen. I think that the real difference here is you should do an en bloc whenever feasible. It is not always feasible. I think it is often feasible, but not always feasible. Why remove the capsule? This goes back to the functional issue and the contaminant issue. So from a functional standpoint, and again, this is if you look at the extremes, it sort of helps to explain the less extreme examples. So the extreme are people who've been radiated. And someone who's had radiation treatment, they have a lot of scar tissue, a lot of capsule, because that's the natural history of radiation fibrosis, is to create a scar type problem. And in those patients, they really have quite a lot of restriction of range of motion. They can have a lot of tightening of the soft tissue of the chest wall. In those patients, oftentimes at the time of a deep flap, I will remove all the scar tissue and replace it with healthy, normal soft tissue. But if you take that same thought process, removal of scar tissue allows for removal of scar tissue at the time of the explant, and resuturing the pec muscle to its normal position should have a functional improvement. I don't have any data to support differences in functional improvement after a total capsulectomy or an en bloc capsulectomy. For me, it makes sense, again, to put the muscle back to its normal anatomic position. The point that I do think is important is if about 20% of our patients, what our data is suggesting, have a bacterial or fungal contamination of the capsule, the only way to eradicate that contaminant is to remove the capsule. And whether it's done in an en bloc fashion, which I think is preferable, or a total capsulectomy fashion, I think it's important to remove all the capsular tissue, which is where the biofilm of bacteria would reside. And in plastic surgery, how do you deal with a contaminated wound? You remove all the contaminants to normal, healthy bleeding tissue. I think it's the same thought process with an en bloc capsulectomy or a total capsulectomy. The reason why I think an en bloc is important is if the implant is ruptured, you don't want to violate the capsule and have silicone spillage into the anatomic space. That's where really focusing on an en bloc capsulectomy allows you to limit the potential for silicone spillage. Again, an en bloc capsulectomy isn't always possible, but if possible, I think that's the better way to do it because it removes that issue of potential for silicone spillage.
So
we covered a lot there. I hope that was not too confusing.
No,
it was awesome.
So I guess the last question that I have is what best case scenario with regard to having explant, what is the most optimal sort of circumstances for somebody who wants to have just one surgery be done and have a good, decent flat result?
Yeah, that I think, to be honest, is the question. Nobody wants to do a lot of surgery. Nobody wants to undergo a lot of surgery. The best time to get something done is really the first time. However, I think that the ability to do a one and done type flat closure ultimately depends on all those variables that we talked about. What was the cancer operation? Did they have radiation? Are we dealing with an explant? Or is this a revision operation after a mastectomy? What type of incision was the mastectomy? Was it a nipple sparing incision? Was it a traditional central scar mastectomy? Are we dealing with somebody who's got an elevated BMI, somebody who had, very large breasts to begin with versus very small breasts to begin with? I think all those issues make it challenging to guarantee a one and done type approach. In fact, I think for most patients that we see, although we try to do a one and done type revision surgery, we're not typically doing it at the time of mastectomy because there's a lot of other things that we're worried about at the time of mastectomy. And I'm talking about the breast cancer surgeon, really. If we're involved, the plastic surgery team, I think we can make the closure much, much more acceptable. If we're not involved, then using all these techniques, some of which we've touched on, fat grafting, local tissue transfer, resuturing the lateral mammary fold area, all those things come into play. And then at the end of the day, it's a question of patient expectation. And I always say that, anybody can do technical surgery, but you've got to have the right plan. If you can do a fantastic technical operation, not have a good plan, that's not a good outcome. And you can have a perfectly fine operation, but have a good plan where you set reasonable expectations, everybody's on the same page, and that's a good outcome. And the plan is really premised not only on what is it going to look like, but who is the person that you're talking to? What is their everyday? Are they a bodybuilder? Are they a grandmother who's a primary caregiver for their 2, 4, and 8-year-old grandchildren? Are they a police officer who has to be able to discharge their weapon? All those things are a part of the discussion to figure out what the right approach is. It's not always a cosmetic aesthetic outcome. Sometimes it's a balance between the aesthetic outcome and the functional outcome.
Well, I just thank you so much for your time. I don't know if anybody else has any questions, but does anybody else?
I actually do. I guess my main question would be, all this information is amazing. I was really, really lucky that I had a good surgical team. I was an explant, so I had not only a general surgeon, but a plastic surgeon. So if somebody is going into explant and they need the best information and the best plan, where do they start? I mean, who do they talk to? I had really good care, and I'm worried, and I see many women that don't know where to start, who to ask, and what should they be asking.
Yeah, I think a lot of it begins with being your own advocate, which is why I think what we're doing is very important, because it's hard for people to advocate for themselves if they don't know what to advocate for. They don't know what is possible, what the options are. So I think every patient has to be one's own best advocate. That being said, I think that the breast surgeon is really the point person to draw in the rest of the team. And whether that team includes plastic surgery or physical medicine rehabilitation or physical therapy or massage therapy, whatever those issues are, I think the breast surgical oncologist is really the point person. But at the end of the day, they do have their own concerns in terms of treating the cancer. And I think part of this is taking those concerns to the next level and saying, I appreciate what you can do for me in terms of, moving my cancer and allowing me to, go back to a normal, healthy life. But part of that means addressing these other concerns, which I know aren't the priority, but they are concerns for me. And is there a conversation that we can have to optimize some of these other concerns? I think that's the type of conversation we need to start having.
I agree.
Yeah.
Thank
I think a lot of patients, well, patients that are explanting, you know, a lot of them, if they're, you know, they're usually explanting because, like you said, they have restricted range of motion, or they have other symptoms that they think are related to the implant. You know, they're so compromised, it's very hard for them to advocate for themselves.
It's true.
It's sort of like being a cancer patient in that sense. They're, you know, they're not 100% in their ability to try to figure out what for explant, and they don't even really understand the terms. You know, when they say explant, I think what I'm hearing from you is that there's no single standard of care. Explant doesn't mean an en bloc or total capsulectomy to every surgeon. It might mean something different. It might mean just simply removing the implant in the office.
Yeah, I think
but it's hard. I don't mean to interrupt. A lot of patients go in and they don't know what to ask for. Like,
right.
Yeah.
Well, it's a tough one because there really isn't a standard here. You know, I think you know, there are concerns with doing a total capsulectomy. You know, you run the risk of hematoma formation. You're taking the capsule off of the chest wall. You know, it's an invasive surgery, and there are drains that are involved there. In some ways, it is easier just to remove the implant. And you know, some people believe. I don't believe this, but some people believe that without an implant in place, the capsule dissolves. I don't know if that's true, to be honest. I've never seen any data in that regard, but you know, if the capsule is retained and there's no infection, no biofilm that we're dealing with, is it acceptable to leave the capsule? I think many people would argue it is acceptable. I think the issue is if there is a contamination, then what do you do? And you wouldn't know that unless you remove the capsule, and there's no preoperative test to determine that.
Mm-hmm.
So you're left with this catch-22.
Yeah.
If you believe it's important to remove biofilm and remove a bacterial contaminant, then you're committed to a capsulectomy. If you believe that it's not important to address any bacterial contamination of the capsule because you've removed the implant and that's the way that you have addressed it, then you would not find it necessary to do a capsulectomy. You know, again, this is whenever there's a crossroads like this, it's because of a lack of data. And there is no clear standard of care because there's no clear data as to what to do here. You know, what would the answer be? If we could point to these low-grade bacterial contaminants as the potential, as one of the potentials for some of the underlying symptoms that patients have, the more systemic symptoms, that would be an important finding. And the example I always come up with was back in the 80s, no one believed that stomach ulcers were due to a bacteria, and the bacteria is H. pylori. And we believed at that time that ulcers were due to stress and caffeine, and it turns out it was a bacterial contaminant. And it wasn't until we found bacteria in the biopsy specimen of the ulcers that was proven. So you know, these are very difficult things to prove. And that's why I think at a society level, there has to be some kind of discussion. And that type of discussion will only happen if it's pushed by patients.
Mm-hmm. That's why we're here.
That's
why we're here.
Good point. Thank you.
We really appreciate your time. This is extremely helpful. I can't I can't even express how helpful this is.
Well, I appreciate you folks for you know, spending the time with us tonight. I appreciate Erica, who's got her microphone on mute, for organizing all of this, because I certainly did not have the technological wherewithal to do it.
Thank you, Erica.
Thank you, ladies, so much. I really appreciate it. And I will send you guys a link when this is saved to YouTube so you guys can view it and share it.
Wonderful. Thank you so much.
I'm so grateful. Thank you very, very much.
And we hope we can do this again. We have so many more questions.
Yeah,
we have
a lot of questions.
I think a follow-up would be nice. I'd love to get Dr. Kochak and involved as well. Unfortunately, he's at another meeting right now, but I think it'd be nice to build this to a platform that would be useful for people.
Wonderful.
That'd be great.
Thank you. And thank you for all of the work that you do.
All right, ladies. Well, thank you. Have a good evening, and hopefully we'll talk again soon.
Wonderful. Thank you so much.
Bye-bye.